Okay, so we've gotten the explanation for the right syndrome. So let's go to the next, timing of relationship. So another one is the fourth one. We are almost finishing. The association is strong. Is the association strong? So you keep in mind that this guideline and all the following guidelines apply only to studies in which the exposure clearly comes before the disease and there is no confounding. So previously the points before this one show that the predictors or the exposures should come before the disease. So the exposures should be associated or should be the cause of the disease and there is no confounding. So perhaps the most intuitive guideline for causal inference is that strength of the association is very important. When we talk about strength of the association, it's in connection with the odds ratio or the relative rates. For a positive association, we have odds ratio being greater than 1. And for a negative association, we mean odds ratio less than 1 or relative rates less than 1. So let's go and explain the odds ratio. So the strength of the association is very important. Let's see an example. In an outbreak of salmonella infection in Oregon and British Columbia in 1995, when you type in this in Google, it will give you this disease outcome, and it will give you this story. In 1995, a relative risk of 17 was found to be associated with eating alfalfa sprouts in the previous 5 days. In other words, people who ate sprouts were 17 times as likely to become ill with salmonella as were people who hadn't eaten sprouts. So, meaning that those who ate sprouts. So I was explaining to you that logistic regression or linear regression causes there are statistical tests that are conducted to infer causation. So we're saying that those who ate alfalfa sprouts in the previous 5 days were more likely or 17 times likely to become ill with salmonella as were people who hadn't eaten sprouts. So that's the truth. So that study that they did, they saw that the odds ratio for contracting salmonella infection was equal to 17-fold. So it's very high. We know that the normal one is what? Versus 1-fold. This is the standard. So if you have 17-fold, it means that it's too high. It's too high. So those who ate alfalfa sprouts in previous 5 days, they contracted salmonella infection. So these alfalfa sprouts is the predisposition factor for salmonella infection in Oregon and British Columbia in 1995. So we are almost done. Is the association biologically plausible? Biological plausibility means that is it proven by biological phenomenon that what you are seeing in your scientific investigation is the truth? Does it contribute to scientific knowledge? Does it have basis in science? So another guideline for causal inference is that the association you observe between an exposure and an outcome or disease should fit what we know about biology. So our basic science in biology will tell us that if we eat too late, the heart The heart, when you eat too late into the night and you sleep, when you sleep, the heart rate goes down. The heart is not able to perform as it's supposed to perform when you are sleeping. But when you are sleeping, the heart is also supposed to sleep, because the brain has rested and it is shut down. So your heart is also supposed to be what? Beating lower than is expected. So digestion of food in your intestine will be slowed down. So does the finding of your study correlate with science? Does it explain what is already known in science? So if the association makes sense in terms of known biological mechanisms in science, it becomes more likely that a cause and effect relationship truly exists. For example, we know quite a lot about the biological possibility of relationship between smoking and low birth weight. Actually, and our knowledge enhances the likelihood that the relationship is causal. Research has shown that smoking reduces blood flow to the placenta, because most of the smokers have hypertension, and hypertension reduces flow of blood. So when we say flow of blood is reduced, it's also called perfusion. So blood perfusion. So in hypertension, there is hypoperfusion, or limited blood supply. Limited blood supply to the growing fetus. So there is limited perfusion in hypertension. So there is limited perfusion in hypertension, because hypertension, research has shown that smoking reduces blood flow because it causes hypertension. It causes peripheral vascular resistance or vasoconstriction, and that this reduced blood flow means that there is less enough blood flow supplied by the placenta to the fetus, which interferes with growth. So we say that mothers who smoke when they are pregnant, they are predisposed to hypertension. And when there is hypertension, blood does not perfuse the placenta, or blood does not enter enough blood does not enter the placenta, and the fetus gets its oxygen and nutrients from the maternal circulation. So if maternal blood is not perfusing the placenta to give the fetus enough blood, then the fetus will be deficient of oxygen and it will be deficient of food. So this one will lead to low birth weight. Low birth weight. So we can say that maternal smoking leads to what? Low birth weight. Additionally, carbon monoxide, which is a byproduct of smoking, also causes less oxygen to get to the fetus. Carbon monoxide also affects oxygenation. And finally, another byproduct of smoking is cyanide. It has been shown to also cause or slow down fetal growth. And this body of all this biological, the body of biochemical evidence, all points to the possibility that the relationship between smoking and low birth weight is truly a causal one. So any woman who is pregnant and is smoking will end up producing a baby whose weight is less than 2.5 kilograms, and that is what we call low birth weight. And such babies are admitted into the neonatal intensive care unit. So such fetuses are admitted into the neonatal intensive care unit. If you have birth weight of less than 2.5 kilograms, then it means that you are having what? Your baby is having of a lower birth weight. So it has to be admitted into NICU, That's intensive care unit. Intensive care unit. Okay, so let's proceed. We are almost through. So we are still on biological plausibility. Sometimes biological plausibility can be difficult to judge, and what is considered plausible at any given time depends on what is known at that time. The association between Reye's syndrome and aspirin use, for example, was accepted as causal long before any biological explanation was evident, which shows that the lack of a known mechanism does not necessarily mean that the association is not causal. So the association between Reye's syndrome and aspirin use, for example, was accepted as causal long before any. So initially, they were saying that this fatty liver syndrome was caused by aspirin, but later other findings also suggested that maybe the syndrome was there already before the person was given aspirin, but we didn't know that the syndrome was there. So that made that the current finding defeated the initial scientific finding that Reye's syndrome predisposes to what aspirin causes Reye's syndrome. But they said, maybe Reye's syndrome was there before you gave the aspirin. So even though the biological possibility can be there, but your recent study can, or your recent study finding can outweigh that biological possibility. Higher exposure levels carry higher disease risks. So the more your exposure, the more your disease risks. Meaning that the more alcohol you take, the higher the higher you are predisposed to liver cirrhosis. The number of cigarette sticks you consume every day predisposes you faster and at a higher tendency to lung cancer. The higher concentration of fat or lipid or fatty meals or cholesterol you take in a day predisposes you to metabolic syndrome at a faster rate and at a higher or severe gravity. So the exposure or the risk factor, if it is very high, it predisposes you highly, or it has a high odds ratio of predisposing the subject to the condition. So first, the presence of a dose-response relationship like this does not always mean that a cause and effect relationship actually exists. Confounding can still come in here and be responsible for the observed association. So some of the time you realize that the observed association you are seeing that this risk factor, like what we saw, alcohol intake was causing lung cancer so high. But when we found out other factors, we saw that if you are taking alcohol, it means that you are also smoking. So let's see, those who take alcohol and smoke, and they were seen to have very high risk of getting lung cancer. Then we look at those who took alcohol but did not smoke, and we realize that those who took alcohol and did not smoke did not even get lung cancer. So it's very important that the higher exposure levels, even though it increases the likelihood of getting the condition, but it's not always true, because there can be a lurking variable or a confounder. The confounder is also called lurking, or extraneous variable. The confounder is also called a lurking or extraneous variable. So the confounder can be causing that high odds ratio or high effect to be realized, which is what is not good for the study, but it's giving a wrong result due to the presence of the confounder. So it's not always that when the higher exposure will lead to higher risks. No. So the type confounder is there, like age. Then you realize that the result is giving is so high, but it's not making sense at all. Okay, so those still on dose response. And second, the absence of such a gradient doesn't mean that a causal relationship doesn't exist. We may not be able to see the dose response relationship because of insufficient variability in levels of exposure. For example, most women in the US have a dietary fat intake of about 30 to 40% of total calories. There may not be enough women at very low levels of fat intake in the US to see the decrease in breast cancer rate that might occur with, say, 15% of calories coming from fat. So they are saying that if you eat high levels of dietary fat, like 30 to 40%, you are more likely to get breast cancer. But in case we were able to find out those whose dietary level was 15%, did the 15% also cause lung cancer or not? So at that time they were doing the study, they had only 30 to 40%. But if they had come down to 15%, they would have seen that, oh, lower fat level wouldn't have caused breast cancer. Another example of a dose-response relationship may not be evident because there may be a threshold, an exposure level above which additional exposure has no additional effect. So at the 15%, there may be that there will be breast cancer or there will be a protection from breast cancer. It's very important, but they didn't do this study at 15%, and that was the problem. So it's not always dose response. So let's see an example. So for instance, looking at the dose response, we realize that this previous example we used, that the higher concentration of the alcohol was supposed to lead to it led to a higher incidence, and the highest one was 25.2. The crude oil ratio was also increased. But when we adjusted for smoking, we realized that, we realized that alcohol has no relationship with lung cancer, but it's rather the smoking which was causing the higher incidence and the higher odds ratio of people getting lung cancer from drinking alcohol. Meaning that people who drank alcohol initially were seen to be having lung cancer, but they didn't ask them to find out whether they were smoking in addition. So when they were able to ask them in addition to find out whether they were smoking, and they said yes, those who said yes, they saw that they had a lung cancer. But those who were drinking alcohol and they didn't smoke, they didn't get the lung cancer. So that was the essence of the adjusted odds ratio or risk ratio. So it's self-explanatory over here. Remember this slide, we saw an apparent association. So this slide we have seen it already. So let's go. Okay, so the last one is the observed evidence consistent? Consistency over here means that if the study is done in another population, geographical population or geographical setting, like somebody is doing a study in Namibia and I'm also doing the study in Boko, are we going to have the same results, the same findings? What about those who are doing a study in Kolebu and somebody doing a study in Upper East Regional Hospital? Are the findings going to be the same? If the findings are the same geographically, and if they use even different study designs, like retrospective cohort study, like case control study, and they get the same results, it means that that risk factor that is associated with the disease of interest is really a causal factor. It is inferring causation. For instance, there was a study, association of smoking and birth weight. I earlier on told you that women who smoke, pregnant women who smoke, gave birth to low birth weight infants. Meaning that there was a study in Germany, a retrospective cohort study, and the birth weight of smokers' infants were 200 grams. That's the birth weight of the smokers, women who smoked and were pregnant when they delivered. The infants were 200 grams birth weight lower, meaning that their birth weight reduced by 200 grams, meaning that they had a weight deficit of 200 grams. Another study in Switzerland, which also used a retrospective cohort study design, had the birth weight of smokers' infants were reduced by 190 grams. And also they found a relative risk of 3, meaning that the odds ratio or the relative risk was higher than 1, which is 3. So it's a predisposition factor. In England, there was a retrospective cohort study, and the relative risk for the low birth weight was 2, meaning that smoking was associated with a twofold increased risk of getting increased risk of delivering low birth weight babies. In Washington D.C., a case control study, which is a different study design from the retrospective study, women with low birth weight infants were twice as likely to smoke. So with this study too, women with low birth weight infants also were likely to smoke. Meaning that all these 4 studies have shown that if a woman is pregnant and smokes, no matter the study design that was used, no matter the geographical setting, whether Germany, Switzerland, England, Washington, they all had the same findings that pregnant women smoking will cause a weight deficit or will cause the infant to be of a low birth weight. So smoking is not good because it leads to hypertension, it leads to vasoconstriction, it leads to hypoperfusion, limited blood flow to the placenta for the fetus. And if the fetus is not nourished, is not getting blood, then the feeding of the fetus will be difficult, because the blood that is able to get oxygen and nutrients. So if the blood is not coming, how will this baby grow? So it leads to low birth weight. So we are still on the how consistent is the finding. So this one is explaining this table of the different study designs, different geographical references or settings, all producing low birth weight out of women who smoke when they are pregnant. They gave birth to babies or neonates who were of low birth weight. So finally, a different type of study, a case control study design, which was carried out in Washington D.C. So you realize that all these were retrospective study, but the case control study also confirmed the same findings, meaning that if you have different studies confirming the same finding, it means that the finding is really true. So we end by saying that smoking in pregnancy adversely affects infants' birth weight, meaning that when you are pregnant and you smoke, it leads to you producing babies who are of a low birth weight. Class, we've come to the end of the class. Thank you very much. Any questions whatsoever? Any question? I know. Okay, so what do we do? Please hold on. Let me close the recording.